To the Kanski lecture series, and this is going to be the uveitis part 4, and in this part we are going to discuss about the Fuchs uveitis syndrome. The Fuchs uveitis syndrome, also known as Fuchs heterochromic iridocyclitis or cyclitis, is a chronic non-granulomatous condition diagnosed at an average of 40 years of age. So basically it is an inflammation of the uveal tissue, and is going to be the heterochromia of the iris, mean that there is a difference between the two colors of the iris, and basically it is a disease of the middle-aged male patients. There is no gender or racial predilection. The cause is uncertain, but there is evidence that implicates that a rubella virus. So rubella virus is one of the virus that has been implicated in a case of a Fuchs uveitis syndrome. Signs in toxoplasmosis can be similar, and toxoplasmosis gondii has also been suspected as a cause. So T gondii has also been suspected as a cause. It is possible that most of the anterior chamber activity is due to the blood aqueous barrier breakdown rather than inflammation. So, what will be the clinical features? Detection is often incidental, finding is usually unilateral 90 to 95%. Gradual blurring due to cataract is common presentation as persistent floaters. Heterochromia may be noted, so there can be floater presentation and there can be cataract. The patient may be presenting with the cataract formation. So one of the major thing is they're going to be the heterochromic irides. Is demonstrated more effectively in the daytime, and is in most patients affected eye is hypochromic. Its quality is determined by the relative degree of atrophy of stroma and posterior pigment epithelium. So what is happening, that there will be the difference between the color of the two eyes. One will be hypochromic, and hypochromic will be because there will be the atrophy of stroma and posterior pigment epithelium. It may be absent or subtle, particularly in brown eyes. Blue eye stromal atrophy allows the posterior pigment layer to show through and becomes concomitant pigmentation, so that eyes sometimes become hyperchromic. So basically in a case of a blue eye, it can become hyperchromic, not hypochromic. Why? Because in a case of a blue eye, when there is a stromal atrophy, it allows the posterior pigment layer to show, and it will cause more pigmentation to show, and it will cause the hyperchromic. Posterior synechies are absent except occasionally following cataract surgery. AC show faint flare and usually only mild cellular activity. Through exacerbation can sometimes be marked. The eye is virtually always white even during exacerbation. So there will be always some kind of a mild AC activity in a case of a Fuchs uveitis syndrome. Next is the keratic precipitates are characteristically stellate and gray-white in color and are located diffusely over the entire corneal endothelium. Iris nodule 30% on the pupillary border. Coepi tiny crystal Russell bodies may also be present on the surface, iris surface. So basically the KP are diffusely distributed in the case of a Fuchs uveitis syndrome. Very important for the VIA point of view. And iris nodules can be present, and there can be the Russell bodies. Iris atrophy is diffuse with loss of crypts. The iris appears smooth with prominent sphincter pupillae and sometimes blood vessels. Pigment epithelial atrophy can be demonstrated by retroillumination. Iris vessels fine and irregular iris surface vessels are commonly present. Vitritis opacities in the anterior gel may be dense. Posterior subcapsular cataract is extremely common. Glaucoma is typically a later manifestation but is occasionally present at diagnosis. It develops in up to 60% of the involved eyes. Several mechanisms is suspected. So basically the thing to worry about in a case of a Fuchs is the glaucoma and the cataract. One should monitor the glaucoma and cataract and treat accordingly, because you cannot do much about the uveitis. Gonioscopy may show fine radial angle vessels or small irregular peripheral and anterior synechy. The vessels are typically the source of hemorrhage, sometimes seen on the incision into the AC ampular sign. So what is happening is basically there is, in a case of a Fuchs, there are small angle vessels. So when there is a small angle vessel, so when you are trying to make an incision into the iris, it will cause the vessels to bleed, and it will cause the ampular sign in a case of Fuchs uveitis syndrome. Fundus. Peripheral choroiditis, foci or scarring have been reported. There have been increased incidence of the retinal dialysis. Macular edema does not occur except following surgery. Investigation. Diagnosis is clinical, though investigations may be necessary to exclude alternative condition. So what will be the treatment of Fuchs uveitis syndrome? So basically the treatment of the Fuchs uveitis syndrome is to monitor for the patient for the glaucoma and cataract. There this steroid is one that is not used in a case of a Fuchs because they are typically non-respondent to steroid. Long-term monitoring is indicated to detect glaucoma and other complications. Topical steroid may be used short-term for moderate to severe exacerbation, but are generally not thought to be helpful in the management of the chronic low-grade inflammation. Cataract surgery carries an increased risk of complication, poor mydriasis, and the possibility of the post-operative hyphema. Increased inflammation, worsening of glaucoma control, and zonular dehiscence should be considered. Preoperative topical or systemic steroids are used by some patients. So, posterior subcapsular cataract is common in a case of a Fuchs uveitis syndrome. So, but there are certain complications that you must know for the patient operating with the Fuchs uveitis syndrome with cataract. So it can have a poor dilation problem, it can have a hyphema post-operatively, it will have increased inflammation, it can have a worsening of glaucoma and zonular dehiscence. So sometimes you can use the preoperative topical or systemic steroid. Glaucoma can be difficult to control medically. Surgical options include a glaucoma drainage device or trabeculectomy with mitomycin C enhancement. Pars plana vitrectomy may be considered for visually problematic vitreous opacification. Uveitis in juvenile idiopathic arthritis. Juvenile idiopathic arthritis. So basically, it is a arthritis in a pediatric patient, and the patient sometimes present with the uveitis as well. JIA is by far the most common systemic disease associated with childhood interior uveitis, with prevalence of about 1 in 1,000. It is defined as arthritis of unknown etiology that begins before the age of 16 years. So, arthritis that begins before the age of 16 years. So, that is why it is called juvenile and persists for at least 6 weeks. Up to 50% of the children affected have persistently active disease after 10 years. It may result from exposure to one or more unknown antigen in genetically predisposed individual. Immunomodulatory treatment should be considered early in the course of JIA, which is the commonest systemic disease associated with childhood interior uveitis. So I just forgot to take the pictures. So you can see this is a Fuchs uveitis syndrome. A is showing right eye involvement, showing hypochromic eye, with and B is showing diffuse stellate KPs. C is showing coepi nodules with iris atrophy and loss of stromal architecture. D is showing band-like posterior pigment layer atrophy seen on retroillumination. E is showing posterior subcapsular cataract seen on retroillumination. F is showing angle vessels and small peripheral anterior synecdoche. So let's get back to the juvenile idiopathic arthritis. So what are the clinical features of the JIA? So arthritis. JIA is classified by the International League of Association of Rheumatology (LR) 2004 revision according to the extent of joint involvement during the first 6 months. Oligoarticular is the most common form. 4 or fewer joints are involved. The knees the most commonly, followed by ankles and wrist. So basically, they can be oligoarticular. So it is most common form, and what is happening that there are 4 or fewer joints are involved. Most commonly involved are knees, followed by ankle and wrist. So this is you can see inflammation of the knee in the child with juvenile idiopathic arthritis. Girls are affected 5 times as often as boys. So girls are more affected than boys, with the peak onset around 2 years. Some patients subsequently develop polyarthritis. About 75% of the children are ANA positive, a strong risk factor for uveitis, which is commonly affecting about 20% of the children of this group. So ANA positive is one of the risk factors of developing a patient with arthritis or uveitis. So next is a polyarticular. So it is a rheumatoid factor negative, affects 5 or more joints, typically both small and large joints symmetrically. The female to male ratio is 3.1. So in this, the females are also more common, but they are almost 3:1. The disease may commence at any age throughout childhood. Systemic features such as fever and rash may occur but are milder than a systemic onset form. About 40% of the children are ANA positive. Uveitis occur in 5 to 10% of the cases. So in this case, it is less common than oligoarticular or polyarticular, but in this case the uveitis occur 5 to 10%, and it is a rheumatoid factor negative. Then is polyarticular, with which the rheumatoid factor is positive, again affects the 5 or more joints, may resemble adult rheumatoid arthritis. There is a very low risk of uveitis. So rheumatoid factor is positive, is a decreases the risk of having the uveitis. Systemic, also known as Still's disease. Systemic features such as fever, episodic erythematosus, macular papular rash, lymphadenopathy, and hepatosplenomegaly may precede arthritis. So sometimes systemic features are preceding the arthritis. The disease occurs with equal frequency in boys and girls and may occur at any age throughout the childhood. The majority are negative for ANA, and uveitis is rare. Enthesitis related, where is an inflammation of the tendon or ligament attached to the bone. It is inflammation of the connective tissue where tendons and ligament attached to the bone. Psoriatic and undifferentiated are 3 other forms under the LR classification. The first 2 have a relatively high risk of uveitis, but risk in the later is usually low. So basically, according to this classification, the most commonly having a risk factor are those with the polyarticular. Then there is a polyarticular with the rheumatoid factor negative, and then polyarticular with the rheumatoid factor positive. Anterior uveitis is a key cause of the morbidity in juvenile idiopathic arthritis. It is particularly common in oligoarticular juvenile idiopathic arthritis and relatively frequent in several other types. Progression to blindness have been high in the past but shows a declining trend in the recent years associated with improved screening and management. Arthritis usually antedates the diagnosis of uveitis. So next is a presentation. The uveitis of the GIA is particularly dangerous because it is invariably asymptomatic and must generally be detected by screening with slit lamp examination. So basically, the patient is usually asymptomatic, so that is why it is more dangerous, because you are unable to diagnose the patient. Even during acute exacerbation with a +4 aqueous cells, it is rare for the patient to complain, although a few repaired and increased in vitreous floater. Often uveitis may not be suspected until the parent recognizes complications such as strabismus or the abnormal appearance of the eyeball due to band keratopathy or cataract. So generally the patient do not present with the such kinds with the symptoms. So patient is asymptomatic. That is why there is a lot of problem in diagnosing the patient. Injection is usually absent even in the presence of severe uveitis. So basically there is no conjunctival congestion in the case of juvenile idiopathic arthritis. Inflammation is chronic and non-granulomatous. Both eyes are affected in 70%, and there is a symmetrical severity of inflammation. During acute exacerbation, the entire endothelium shows dusting by many hundreds of cells, but hypopyon is absent. So inflammation is chronic, non-granulomatous with the symmetrical severity. Posterior synechiae are common in long-standing undetected cases. Band keratopathy and cataracts are common in severe cases. Other serious complications include glaucoma, common amblyopia, maculopathy, cystoid macular edema, epiretinal membrane, cyclitic membrane, and phthisis. So these are all the complications of uveitis. It can cause glaucoma, amblyopia, maculopathy, cystoid macular edema, epiretinal membrane, cyclitic membrane, and the phthisis. Prognosis in about 10% of uveitis is mild, with never more than +1 aqueous cells, and persists for less than 12 months. About 15% of the patient have one attack lasting less than 4 months. So basically 10% of the cases the uveitis is mild and it persists less than 12 months. 15% have an attack lasting less than 4 months. The severity of the inflammation varying from +2 to +4 cells. So in this case the basically the 15% of the cases, the uveitis have plus 2 to plus 4 cells. In 50% of the cases, the uveitis is moderate to severe and persists for more than 4 months, and in 25%, the uveitis is very severe, lasts for several years, and respond poorly to the conventional treatment. So basically, the 50% majority of the cases are moderate to severe, and they persist more than 4 months. And next is the 25%, which is very severe and lasts for several years. The presence of complication at initial examination appears to be an important risk factor for the development of subsequent complication regardless of therapy. Good visual outcome can be achieved by early case recognition and rapid referral to a specialist for immunomodulatory therapy. So what are the investigations that you can do in a case of a juvenile idiopathic arthritis? First of all, you have to do systemic diagnosis and management should be performed by a physician familiar with the management of juvenile idiopathic arthritis, typically a pediatric rheumatologist. So first you have to treat the systemic condition. Then you can do certain tests to know about the risk factor for the uveitis. HANA positivity denotes an increased risk of uveitis. HLA-B27 testing is useful in differential diagnosis and if present may indicate an increased risk of uveitis. Rheumatoid factor is also useful in a differential diagnosis. Screening. There has been a shift in the recommendation towards the long-term 4 monthly review interval in all high-risk categories. Review should continue in most of the cases until the age 12 years. So you should review the patient with the ophthalmologist for every 3 to 4 monthly until the 12 year of age. Initial examination within 6 weeks of first diagnosis of JIA. Delayed early examination is an important cause of morbidity. So if a patient is diagnosed with the JIA, you have to see the patient within the first 6 weeks. Visual symptoms or suspicions of ocular signs, synecdoche, cataract, pancreatopathy should lead to urgent ophthalmological referral and slit lamp examination within a week. So if there are certain complications, then within a week. Initial 2 monthly examination for 6 months may be considered for all the newly diagnosed oligoarticular, psoriatic, polyarticular and enthesitis patient regardless of ANA status, followed by 3 to 4 monthly. So first you have to see the patient every 2 monthly for 6 months, mean 3 times in a 6 months, and then you do after every 3 to 4 months. Then polyarticular every 3 to 4 months, but some guideline reduces the interval to 6 monthly after a number of years. High risk factors that may be considered in deciding whether to alter the interval include the presence of NA onset before the 7 years of age and female gender. So these are all the poor risk factors, mean they are NA positive if the patient is diagnosed before 7 years of age and the patient is female. Systemic onset and the polyarticular RF positive patient, most authorities recommend at least an initial screening examination with some guidelines suggesting annual review. So these are having the a good prognosis for the uveitis, means that there is a less chance that the patient will develop uveitis, so you can do annual examination in the case of a polyarticular RF positive and systemic onset. Missed appointment must be effectively detected and the patient rebooked. Information for parents should include an emphasis on the importance of compliance with screening as well as the need to ask urgent advice should there be any cause of concern such as visual symptoms, ocular redness or clouding or abnormal pupil. Self-monitoring. At eventual discharge from screening, patients should be warned to self-monitor by checking the monoocular vision at least once a week because the risk of uveitis has not entirely disappeared by this age. They should also attend an optometrist annually for an eye examination. Selected patients such as those with the learning difficulties may require ongoing ophthalmological screening. So what is the differential diagnosis of a patient with a juvenile idiopathic arthritis? So particular consideration in children include idiopathic juvenile chronic iridocyclitis, otherwise healthy patient with juvenile chronic anterior uveitis. Other types of juvenile arthritis and uveitis including juvenile reactive arthritis, juvenile inflammatory bowel disease associated arthritis. So you can always look for pair. Juvenile sarcoidosis is one of the differential diagnoses. Pulmonary involvement is less common than in involved, maybe granulomatous and involve the posterior segment. Lyme disease usually present with an intermediate uveitis in conjunction with a significant anterior uveitis. Intermediate uveitis, 20% of all the cases of pediatric uveitis. Then there can be differential diagnosis of the neonatal onset multi-system inflammatory disease is a rare idiopathic chronic relapsing condition that predominantly involves the skin, joints, and the central nervous system. About 50% of the children develops recurrent anterior uveitis. The absence of posterior synecdoche and no tendency to glaucoma and cataract formation are characteristic. Masquerade syndrome such as anterior segment involvement by retinoblastoma. There can be familial juvenile systemic granulomatosis. Palau syndrome is a rare autosomal dominant disorder characterized by childhood onset of granulomatous disease of skin and eyes, panuveitis, and multifocal choroiditis in joints. So, how will you treat a patient with the juvenile idiopathic arthritis? The aim of treatment should be the suppression of all active inflammation. These children will be referred as soon as possible to uveitis specialist. So first, topical steroids are initially effective in 80% of the case. So basically, steroids are the mainstay of treatment, topical steroid. Mediatic agents can be used to prevent synecdoche formation. A relatively short-acting preparation such as cyclopentolate should be prescribed and discontinued as early as possible, particularly in monocular treatment of younger children susceptible to development of amblyopia. So, mediatic agent is usually used in acute attacks. Then you can use periauricular steroid, oral steroid, NSAIDs, systemic immunosuppressive agents, for example, methotrexate, infliximab, adalimumab should be considered at an early stage as this has improved the overall visual prognosis in recent years. These children are usually under the management of uveitis specialists, typically working in collaboration with the pediatric rheumatologist. Etanercept should be avoided as it can result in a severe worsening of inflammation. So there are certain immunomodulators that you can start as early as possible because they increase the visual prognosis. For example, methotrexate, infliximab, and adalimumab. If there is a secondary glaucoma, if topical medication does not control the IOP, the surgery may be needed. The long-term result of the trabeculectomy with mitomycin C in children with GIA are improved if they are using the systemic anti-TNF medication. Bewildered implantation also result in a good long-term IOP control, but is associated with 5% risk of hypotony maculopathy. So basically, if medications are not controlling the IOP, you can always go for surgery in a case of a pediatric patients. Cataract extraction is often needed. Primary IOL implantation was a controversial issue in the past, but a low complication rate with a good visual results have been recently reported with this approach in children on immunomodulatory treatment. Posterior capsular thickening requiring treatment occur in approximately half. So you can always go for cataract extraction if the patient is presenting to you with the cataract. So that's it for the uveitis part 4. See you in the next lecture.